Good morning. First, I would like to thank to the organizing and scientific committee this very kind invitation to be here. It's really a pleasure, and especially because I'm able to share with you our experience in the rehabilitation of the total edentulous patients, and especially now that we are introducing a new material, the PIC polymer in our practice and in our rehabilitation protocol. So for these last 20 years, our main objectives have been trying to achieve a simple and cost-effective procedure for providing fixed teeth to edentulous patients. Also, we would like those fixed teeth to be placed immediately in the time of the surgery. And, of course, with high success rates, both for the implants and also for the prosthodontics rehabilitations. And as we know, these patients are long-term patients, and of course, the ability to maintain and to replace and repair some problems that might come with the time, it's also very, very important. And we have succeeded with two different protocols. The first one was the all-on-4 protocol, and it's a surgical protocol which allow us with 4 implants only to achieve the correct support for our bridges. And then the MALO Clinic bridge that is being developed, especially for the all-on-4 surgical protocol, and will allow the patient to have the fixed teeth with highly aesthetical and functional capabilities. So, of course, from the beginning of MALO Clinic, we have been facing different approaches to implantology, from subperiodontium implants to bone grafting, and then the all-on-4, and now with the ability to place an all-on-4, but all supported by zygoma implants, like you see in this last picture. And the stresses that these types of surgical approaches causes on our bridge is totally different from 10 or 8 straight implants. So it forces us to change our protocols. And first, what is all-on-4? Well, all-on-4 is a surgical procedure which only needs 4 implants, but these 4 implants needs to be perfectly placed, or at least in some specific places. The distal implants usually are angulated, are always angulated, with angulations that should not exceed 45 degrees. I would say that 35 is more than excellent for our needs. In some cases, we don't need the jawbone to place our implants, and we can go for an extra-oral zygomatic approach to place those implants. So we go for the malar apophysis. And with this technique, we are also suggest in some situations to use cantilevers. And of course, that will cause additional stress on our fixed bridges. And we have 2 different types of bridges. The first one, which is placed in the surgery day, it's an all-acrylic bridge. And then we need another final bridge, and a bridge much more complex and with 12 teeth. And in some situations, I would say 80% of the situations, we are also prepared to do some bone reduction to regularize the jawbone and also to hide the transition between the natural gingiva of the patient and also the artificial gingiva that is almost every time used. So we divided our protocol in 4 different steps. The first one being the diagnosis step. Then we move to the surgery, and immediately on that day we place a fixed acrylic bridge, an immediate bridge, and after the healing and the osteointegration period, about 4 months, we move on to the final bridge. This first diagnostic phase is extremely important. and we should define several things immediately on that phase. The type of rehabilitation that the patient is going to need, which type of prosthesis it will be adequate for the patient, where is the transition zone, and how is the smile line and the lip support. And these four parameters will make us decide if we need to do some bone reduction or not. And usually in 90% of the cases, we should do the bone reduction. So for the lower jaw, for the mandible, it's very easy. Usually it's always a classic all-on-4. But in the maxilla, we have several possibilities. The first is when we have the perfect case, and in which we have huge bone volume, and we can decide if we want to place parallel implants for fixed rehabilitation, or we can also go for the all-on-4. As the bone gets less and less, our opportunities also are shrinking. So when we only have bone until the first premolar, we still can do some, the first molar, sorry, we should, and we can do also the all-on-4, but the parallel implants are also a very good solution. But when the bone starts to decrease in quantity, then the problems arrive. And of course, when we only have bone until the second premolar, we can also go for parallel implants, but then we know that we need the cantilever. Also, we can go for the all-on-4 standards, and usually we are able to decrease that cantilever in the final bridge. When the bone is on the level of the first premolar, then we cannot longer do parallel implants. We can, but first we need to add a new surgery. Usually we do some bone grafting and we raise the sinus so we can place parallel implants further back. But we can, with the all-on-4, we can decrease also that cantilever because the last implant will be more posterior and will give more support to the fixed prosthesis. Then when we only have bone to the lateral incisor, and these are the cases in which we started doing zygomatic implants because we have anterior bone and we can place straight implants in the anterior region, but we cannot go not even for the distal tilting implants of the all-on-4. So we are doing what we call the hybrid cases. We are doing the zygoma implants on the posterior with a different approach from the classical to avoid the screw exit holes to be very palatal, and we place straight implants on the anterior. And on the most dramatic cases, in which we have no bone whatsoever, we go for the double zygoma. And with these cases, we place 4 zygoma implants, 2 usually exiting on the level of the premolars, the second premolars, and the anterior ones on the canines. And with those 4 implants, we can achieve the support that we need for our final bridge. So, again, why we do the all-on-4? First, because usually these populations, these patients are old, they have systemic and health problems, and we want to decrease and to avoid the need for extra surgeries. So we do the all-on-4 especially to avoid the bone grafting. Also because we know today, with the follow-up that we have, that even with these tilted implants, we have a very high success rate, both for the implants, both for the prosthesis. And because there are only 4 implants, it's much easier for the patients to clean them properly. And by cleaning them properly, it will decrease the biological complications that we see in the long-term follow-ups. And also because psychological, it's very important for the patient to have their fixed teeth immediately, but also because sometimes the provisionalization is the cause for another problems that we might find in the follow-ups, usually with removable dentures. And so, what is MALO Clinic Bridge? MALO Clinic Bridge was developed as the necessary reconstruction for the All-on-4. It has some specificities, like it's always a one-piece bridge. We don't do segmented restoration, because with 4 implants that would be impossible. Usually it has always false papilla and some soft tissue artificial material that can be either ceramic or acrylic or composite material. It's meant to be used with cantilevers. Of course, we try to decrease the length of that cantilever as much as possible, because we know that it's one of the main causes for functional problems in the future. And usually it can be designed in full acrylic for the immediate provisionals, metal acrylic, and ceramic, metal ceramic for the final bridges. And now we are also using PIC as the infrastructure, replacing the metal. So it can also be infrastructure of PIC covered with acrylic or composite or with ceramic. The goals that we want to achieve with this type of restoration are very simple. We want the best mechanical characteristics, and sometimes we confound that with rigidity. And I think for this type of rehabilitation, sometimes rigidity is not the best quality that we can have on our materials. Also, we want to have a very consistent and precise fit. And we know that with the CAD/CAM systems, our passivity is increased by a lot. We also want to use high-density acrylic for the artificial gingiva, so we can achieve a high surface luster and polish, and by that way keep the tissues more healthy. And we want something that we can repair in long terms, in a simple and economical way. And classically, this was what we were doing. We were using titanium as the material of choice for the infrastructures. In this case, you see a Procera infrastructure. And this infrastructure was prepared to be completely covered with acrylic teeth and pink acrylic. And of course, with this, we can achieve a good aesthetic result. It all depends on the teeth, the acrylic teeth that we are using, and of the technician, of course. But in some cases, we want to add another level of aesthetics, more customized aesthetics. And in these situations, we were using the ceramic bridge. And the ceramic bridge also pretends to be a very aesthetics rehabilitation with the same mechanical characteristics that we wanted for the acrylic. But instead of being covered, layered with ceramic, we were using ceramic crowns, individual ceramic crowns. And the framework had a different design. And each one of these crowns are cemented in this infrastructure. The main advantage is that if we need to repair some chipping of the ceramic, we just need to replace one of the crowns. We don't need to remove the whole bridge and repair the ceramic in the oven. We just need to remove that crown, to place a provisional, do a new impression, and we can cement a new final crown in the infrastructure. The infrastructure is, the support is not critical, because we can change the support of the ceramic by using lithium disilicate, or we can use zirconia copings with more support, and we have the same acrylic for the artificial gingiva. So this is the framework that we were using. And here you can see in the beginning, we were using individual crowns, zirconia ceramic crowns. But then again, we find a new way to simplify this, because for the technician, it's of course always difficult to repeat one incisor if there was some kind of fracture in the long term. So we change and we start using lithium disilicate. So this is how we were doing it before the peak, and we can see the infrastructure with the opaque on the preparations and the lithium disilicate crowns before crystallization. And we also published some paper about this technique, because the introduction of the lithium disilicate really makes that a lot easier to repair, because we have the memory, we have the file, we just need to order a new crown, and there's no layering again for the technician. It's a lot easier in the long term. And by having ceramic, we can have completely customized cases. We can do from B1 to A4 crowns. We can change the shape, we can change the length, we can change the effects, and we can obtain a very customized aesthetic result. And we can, for different patients, find different smiles, and sometimes all our patients tend to have the same smile. Here we can avoid that. But of course, we know that this is something that is beautiful when we place it, but usually in the long term there's changes, and unfortunately for the worst. And there's not a lot of literature and analysis of which the problems are, and the comparison between different materials for the infrastructure and for the veneering materials. But we know that usually the problems arises with the veneering material. Also, we can have screw becoming loose from the prosthetic screws, from the abutments, and in the worst case scenarios, we have the fracture of the framework. And we've been there with all those problems. This is a clinical case of one of my patients, a heavy bruxer, and we can see that we have almost all the problems that we can find on the articles. We have some crowns that become discemented. We have chipping of ceramic. We have chipping of the artificial acrylic. And the most strange for me, because it really needs a lot of pressure and a lot of strength to do that, the fracture of the acrylic teeth in the lower bridge. And it's easy for them to become loose, sometimes from the infrastructure, but to break like that, it's really a matter of high strength and high pressure from this patient. Here we can see the chipping of the zirconia crowns. We all know that zirconia is prone to that problem, but this is not just the zirconia being sensitive to chipping. And here, a fracture of the infrastructure. And usually, this type of problems only happens after some years, and it's due to the titanium fatigue. Another situation in which the cylinder has a crack. And of course, all these situations are very catastrophic, because these imply redo the whole work. New framework and new everything. So by recent articles, we know that by changing the veneering materials and the infrastructure materials, we change the pressure in the system, if you want. We changed how the forces are absorbed and how they will be relieved. And with these articles, sometimes we see that it's not a matter of just having acrylic in the veneering system as a better option of porcelain. No, it's the combination of all the materials. Sometimes a better material for the veneering, if we change the infrastructure, then we will have a worse case. So we decided to give a try to PIC, and we were fortunate to be in contact with JUVORA, and we decided to try a clinical assay to see how this material will behave in this kind of rehabilitations. And so far we have 34 patients in treatment, and we have already placed 46 PIC infrastructures. The average follow-up is still the preliminary results, but the average follow-up is 6 months, ranging from 1 month to 14. So this was the system that we were using. It's called PalletJet, and uses a special acrylic, special flask, and this machine that will inject with high pressure the acrylic into the flask. So this is the hydraulic amble that will make the acrylic fulfill all the spaces where the wax was. And of course, this creates a much more rigid material. And I think it was okay for titanium, because titanium is also very rigid. But when we introduce a more resilient infrastructure material, we start having those cracks. And so we changed. We are using this device. It's called Fast Protect. It's a mix between an articulator and a flask, and it's very useful not only for making duplications, but also to make the acrylization without having that very hard material. And so here you can see in the acrylization process where the excess of the material are coming out of the flask. And now I will show you some of the cases, but first I would like to say that the PIC is really doing very, very well. And I know, I have that idea that we are stretching the indications of PIC, because we are doing cantilevers, and we are also doing more than 3 pontics sometimes in the same framework. So it's really a test for the material. So this is the first case, a very nice lady. She was wearing a removable upper denture, and also in the lower. And this patient, of course, had a lot of chewing problems and static problems. So in this situation, we proposed to do an upper and lower standard all-on-4. And this is the same patient in the first oral hygiene appointment 10 days after surgery. So what you see here are the immediate provisionals. And you still see the sutures present. At this point, they will be removed. And now the patient will go for the osseointegration process. And for the next 4 months, we try not to do anything to her. After the healing phase, we start by doing the final impressions. And this is how we do our impressions. We use screw retain impression copings, and we ferrulize them with some hard metal bars and low contraction acrylic. And we use normal silicones. in this case, it was used putty soft and individual tray. And after pouring the final impression, we obtained the master casts. Because with PIC it's very difficult to see the passivity, usually we do a passivity try-in. We do some bars with metal copings on these models, and we tried the fit in the patients. And then we also take impressions of the provisionals. The provisionals for us are our references, so we try to keep as much references in the process as possible. And after we have the articulation of the provisionals, we always cross-mounting the other models, meaning that we remove the patient provisional, we screw them in the master model, and we do another articulation of this master model. And then we remove the lower, and we articulate the lower master model with the provisional. And in this way, we can change all the models and having all the references from the provisionals. And besides that, we also do these silicone indexes. These indexes will help the technicians with the wax-up procedures and, if necessary, some finishing and some reduction of the infrastructures. Then we scan the bar, or we design it in 3D in the software. And after finishing, we mill the bar, and this is what we obtained. So you can see in an occlusal and in a more apical vision, the two infrastructures for these patients. Here you see the master models, and already with the PIC infrastructures on. This design is very simple. It's just like a bar design just for support of the acrylic teeth and the pink acrylic. And then the process for bonding the pink acrylic. You can see the primer, the bonding, and now it's ready to, with, again, the fast Protect system to make the acrylization of the pink material. We can place the acrylic teeth inside, and then everything is closed, the flask is closed, and the excess of acrylic will come out, and we will finish the final bridge. And you can see here that the area of the cylinders is also only in PIC material. And that's perfectly okay. It's even better than having acrylic, because we know that PIC is a very biocompatible material. Now, an example of the lower. And here we can see the patient with the final bridge, upper and lower. In this case, we did upper and lower acrylic. This study is being conducted by 4 of our senior dentists and with 2 technicians, so we want the procedures, both from the clinical point and from the lab point, as standard as possible. You see here, in occlusal view, in this situation, there's no PIC standing out of the framework. Everything is wrapped around with this acrylic. And you can see the X-ray. So another case, in this case, it's a different situation. We have here a patient with only 4 teeth in the upper jaw with periodontal problems. In the lower, we decided to invest in her oral hygiene in order to keep these teeth as long as possible. And in the upper, we decided to do an all-on-4. Here you see the classical aspect of the all-on-4 implants, with the distal implants being tilted. Again, the final impressions with the ferrulized impression copings. Again, the same articulation. Every case is done in exactly in this way. And again, the final peak frameworks in the process of being primer and bonded in order to have the best link possible between the pink acrylic and the peak framework. And the finished case before polishing. And again, the final X-ray. In this case, I think we will not have any problem for sure because we have a very high framework and a very stable occlusion, so it will be for sure a success. And again, a happy patient. So in these situations where we have natural dentition as antagonist, I will show you, this is the first case, I will show you different options that we are testing. In this case, we did like we were doing before, but we only changed the infrastructure material. We moved from titanium to PIC. But in the next cases, I will share with you different approaches that we are testing to see how they will result. In this situation, we did it differently. Here, again, the upper teeth were hopeless, and we decided to do an all-on-4 in the upper and to keep the lower teeth as much as possible. This patient wanted to keep some small gingival smile. It was her characteristics, and we promised that to her. So you can see how these upper teeth were heavily restored with post-encores and very huge restorations. Here, after extraction and placement of the implants, a shorter ridge, so the implants were closer to each other. And here we have the immediate provisional, still with some sutures there. So this provisional was used by the patient for 4 months, and after that we move always the final impressions to start, articulation with cross-mounting of all the models. And here we decided to do a full contour bridge. So in this situation, we made the wax up, and we scanned the wax up in order to obtain the framework. This framework, as you see, has also the teeth in her. So what we did here was we made a silicone index of the wax up, and then we reshape the PIC infrastructure in order, we did a cutback in order to gain space for veneering the labial side of the teeth. Here you can see in the left side the PIC infrastructure with composite veneering only on the buccal. And in the areas where it's going to be covered with pink material, we use it also composite material instead of acrylic. And this is how the final bridge looks. It has composite on the buccal, but the occlusal is the PIC itself that is doing all the contacts. Of course, the X-ray is slightly different because we have the composite material showing up in the X-ray. And we are seeing how the PIC will resist to the functional stresses of mastigation. But aesthetically, a very good result, and the patient was very happy. Something that all these patients, they immediately say, it's the feel of these rehabilitations is very comfortable. They feel much, I think, more comfort with this type of devices than with a very rigid device like the ones that we were doing. And here you can see the patient smiling with her final bridge. Of course, the static result will depend on the technician. This is hand layering composites, so it can be better or worse, but it's not the point that we want to see here. What we want to see is how these materials will behave in function over time. And the last case, again, a case in which we only did the upper jaw. The patient still has her natural lower teeth. A very happy patient, a very nice lady. And hereafter, the placement of the implants with the immediate bridge. Again, starting always with the final impressions to make the models as accurate as possible. It's extremely important to have this type of bridge as fit as possible, and the cross articulation of the models, in which the provisional is always our reference to the final work. Then we start doing the wax up according to the provisional, and when we have the wax up, we duplicate the wax up into an all acrylic framework. This all acrylic framework was then prepared like conventional prosthodontics. Each teeth was prepared, and this is how it looks before scanning. This framework can be scanned with a digital scanner, and the software will allow us to make some changes if necessary. But this is how it looks in the software before sending it to production. And here we have the final PIC infrastructures prepared to receive individual crowns. So here we will do like the ones that I showed you in the beginning with the titanium infrastructure. In this situation, we bonded individual ceramic rounds to each of those preparations. First, we do a waxing, individual waxing, and then we copy with always the fast protect system. We copy the shape, the outer shape, and by investing and injecting the desilicate, we obtain these Emax individual crowns. The framework was prepared according to the manufacturer instructions to receive these bonded crowns. And after the cementation, we moved to the acrylic, to the pink acrylic. We prepared the infrastructure, and we made the acrylization process. So here it is the final crowns, still with the waxing before the injection of the pink acrylic. And now here we have the final structures. In this case, we left some areas of PIC around the cylinders to have a more reinforced framework, and we choose not to cover that with pink acrylic to diminish the thickness of the bridge. And of course, we know that PIC will behave beautifully in the contact with the oral cavity, so that won't be a problem. And here we have the X-ray. Also, the Emax crowns are not as radiopaque as other materials, but we can see that we have there 12 individual crowns and less opaque infrastructure. And a very happy patient. And here you can see the result. So this is some of the tests that we are doing using PIC. And so far, we are feeling very optimistic with the results that we are finding. And I think that probably in the close future, we will see this material being used much more and in more different applications and with more, probably with more strong indications than we are seeing it now. But I think probably this will be our protocol, and I'm very optimistic to see how it will behave. So thank you very much for your attention. It was a pleasure.